So I'll share from mine. All right, so the time is 12 o'clock. I just want to say good afternoon, everyone. I'm excited to see so many community members join this call and local organizations. My name is Tiffany Scott. I'm the chair of the Opioid Restitution Fund. I want to thank the council members as well who are present on the call today. It is my pleasure to be able to offer the opportunity for community members at large to present public opinion on the Opiate Restitution Fund, and this is going to be a time-sensitive call. Okay, so please be mindful of the 2-minute time frame. We do have a few members who joined us today that would like to present presentations. We're working on that right now. But if we're unable to share your slides, if Christian cannot get them up and I'm unable to do so, please read from your slides. We will greatly appreciate that. You are able to utilize the chat feature. It is open and available to you for those who would like to provide any comments in reference to anything that's being offered on the slides today. I will do my best to walk through them as closely as possible. And with that, we'll get started. You'll have 2 minutes. You will be provided a 2-minute warning in the event that you are beyond the 2-minute time limit. And please, if you hear the warning, please allow us to pause and introduce the next speaker so we can continue in a timely fashion. And with that, I'll begin with Ms. Barbara Allen from Howard County. Good morning, Ms. Barbara.
Good morning, or good almost afternoon. I am Barbara Allen, Executive Director of James Place, and I'm the chair of the Howard County Opioid Collaborative Community Council. I'm also the mother of Jim, the sister of Bill and Tom, and the aunt of my niece Amanda, all who lost their lives to substance use disorders. With that, some of the suggestions I have are, I believe jurisdictions need to include input from families, persons in recovery, and other interested community members. Inclusion can help reduce stigma while opening doors for broader solutions, but it's also an outstanding opportunity for education because many do not understand the services that currently exist. I recommend targeting programs that can be implemented in a timely manner, things that can be done fairly quickly to get buy-in from all concerned. And included in that are suggestions for things like teen trailers. We're walking through and finding out places that our teens and others can hide things. Examples are the Harford County Sheriff's Office and Montgomery County Police. Also the life-saving boxes, again, another Hartford program that include outdoor boxes that include AEDs, Stop the Bleed, and naloxone. I suggest working with partnering with programs already in existence to expand or enhance programs, whether it's within your jurisdiction or cross jurisdictions. There's no need to reinvent the wheel. I very much support co-occurring supported opportunities. Too often there's some battle between mental health and substance use, which I think is useless, even though I recognize the insurance issues. So I support anything that provides for co-occurring support. I've asked for focus on recovery community organizations as well as community-based organizations, those that offer direct services to those who are currently struggling with their recovery, because very often these folks do not have support for their recovery capital for birth certificates, Social Security cards, funds for transportation, food, things of that nature. And look
Thank you, Barbara.
for opportunities.
That's 2 minutes.
All right, if that's it, let me just say thank you very much. Love you all. I'm done.
Thank you.
Ms. Barbara, I just want to thank you for the opportunity to share, and your input is valuable. And also thank the OCC for creating this opportunity for us today. Next up, you have Nicole Harrington from Baltimore County.
I believe we skipped Jennifer Turk.
Oh,
She's who I had next on the list. Sorry, Tiffany.
All right, thank you. Miss Jennifer.
Oh, thank you. Hey, everybody. My name is Jennifer Turk, and I'm a person in long-term recovery from addiction and the executive director of Voices of Hope, a peer-run recovery community organization that serves Cecil and Harford counties. Today, I'm representing MARCO, the Maryland Association of Recovery Community Organizations, to ask you to support what has been historically unfunded local nonprofit recovery community organizations or RCOs. RCOs have been created by people directly impacted by the opioid epidemic. They are people in recovery, family members of those who struggle or have died as a result of addiction. RCOs are filling gaps in the continuum of care by providing a variety of services, engaging with people who use drugs, providing harm reduction services, connecting to substance use disorder treatment, providing transportation, recovery housing, and funding, and providing long-term recovery support through peer recovery specialists, support meetings, and vocational support. RCOs change the landscape of resources in our communities. We are asking you to set aside 45% of restitution funds for capacity building and sustainability for RCOs in Maryland, and to create a subcommittee for implementation and oversight until Marco is in position to do this ourselves within 5 years. Doing so will increase the recovery capital in Maryland. RCOs work with local governments, health departments, treatment, and the community to provide services that reduce overdose deaths, increase access to resources, and promote recovery. Please step up and fill the need. The results of this investment will pay off for generations to come. Thank you.
Thank you, Jen. Next up, we have Nicole Harrington.
And that would be Nicole Harrington going once from Baltimore County. And twice for Miss Nicole Harrington, Baltimore County. And we will table Miss Nicole Harrington for future discussions. Thank you.
Next up, we have Bernard Guyby Foster from Turk House, Inc., the Chief Executive Director, or Chief Executive Officer. I apologize.
Okay. Hello, my name is Maud, and I'm representing Bernard JB from Tech House. Tech House, we've been doing addiction for over 50 years. Currently, we run the Crisis Stabilization Center for the Baltimore metropolitan area and Maryland at large. We run one of the biggest crisis centers. Currently, we are seeing about 300 to 350 patients a month at the Substance Use Crisis Center. It's a grant-funded program. We have few challenges with the grant because we have clients coming in that sometimes we need to transport them to their methadone programs for dosing and also for other medical issues. We also have to feed these clients, which sometimes become a challenge for us, and finding them the next level of care. Currently, we want to submit that per the regulations and stipulations of this crisis system coming on, the amount proposed will be a huge challenge for those of us in the crisis sector to meet the demands of what we do with these clients, and especially for mental health crisis and the services that would involve in maintaining a standalone crisis center. And the amount proposed would never, or is almost abysmal to meet our current demands and what it requires us to be able to function or provide adequate and well-prudent services to the communities and the population we deal with. Currently, as you all know, the EDs are very well overwhelmed, and the crisis center is almost becoming very highly medicalized because we are seeing a lot of patients with very complicated comorbidities. That is, we have to treat as well as deal with their substance use. We sometimes have to transport to the emergency room because some of these patients are above, or their level of care is a bit more complicated for us, which causes some of this burden. And we tend to have issues in transferring patients to the emergency room for higher level of care. and all that stuff. So we propose that maybe
That's 2 minutes,
funding,
Maud.
thank you, funding should be more well allocated. Thank you.
Thank you. Next up is Carmen, the president from Never Use Alone, Inc.
And that is Miss Carmen going once and twice. And we will table Miss Carmen until the next public listening session. Thank you.
All right, we have Ellen Weber, Senior VP for Health Initiatives from the Legal Action Center up next.
Thank you so much. Appreciate the opportunity to present. I'm Ellen Weber. The Legal Action Center is a law and policy organization that works on behalf of individuals with substance use disorders, arrest and conviction records, and HIV or AIDS. In Maryland, we convene the Maryland Parity Coalition to expand access to care through enforcement of the Mental Health Parity and Addiction Equity Act. We urge you to consider supporting what we've been calling the Consumer Health Access Program, which would help Marylanders with substance use disorders and mental health conditions enroll in insurance, understand and navigate their benefit coverage, and get legal assistance when a denial of care must be appealed. In this time of unprecedented need, CHAP would be a one-stop shop, a single point of entry to help consumers get the care they need and assist their providers who are often their advocates. Many Marylanders never access substance use treatment because their insurance system is just simply too complex, and individuals and families need substantial support in the midst of a crisis. We envision CHAP as composed of one central non-governmental entity with nonprofit organizations across Maryland so that it could have both on-the-ground presence in communities for outreach, education, and assistance, and also a virtual helpline and portal. It would be staffed by individuals with lived experience to reduce stigma and would have an equity focus to ensure culturally appropriate services and identify inequities in care based on race, gender, identity, and language. So CHAP would work on all insurance-related problems, regardless of the payer, whether that's private insurance, Medicaid, employer plans, or Medicare. It would provide soup-to-nuts services from enrollment to understanding insurance coverage to finding a network provider or filing a complaint. No entity in the state offers this comprehensive service, and it would address both individual needs and system-wide problems, whether that's a provider network, Parity Act violations, or services that aren't covered. So thank you for your consideration, and we will look forward to providing you some additional information in writing.
Thank you, Ellen. Up next is Lisa Lowe from FACE, Addiction Maryland, Family Advocates Coalition to End Addiction in Maryland.
And that is Miss Lowe from FACE going once and twice. And we will table Miss Lowe into the next listening session. Thank you.
And up next, we have Kimberly Ryan from CCHD.
That is Miss Ryan going once and twice. And we will table Miss Kimberly Ryan from CCHD into the next public listening session. Thank you.
Up next, we have Daniel Morrissey from South Shore Recovery Club.
Mr. Morrissey called once and twice and tabled until the next public listening session.
Up next, we have Harriet Smith from Baltimore Harm Reduction Coalition.
Hi there, I'm Harriet Smith from BHRC. I've been lucky to be at BHRC long enough that I remember advocating on behalf of this bill and advising the bill drafters on language. And so I'm here to talk more about process than a specific funding priority. In 2019, when this bill was being drafted, we advocated really strongly that there be community input, modeling not just input in the way that maybe you would have folks vote on a priority, but actually modeling after the Baltimore Youth Fund, which has a robust community-driven process to actually, write the priorities together, not just vote on which ones should be top, and to choose the areas together that should receive the bulk of the funding. That didn't make it into the bill. The bill sponsor was like, oh, we got to hurry up. And that happens and it's okay. But I wanted to just be here to let you all know there's a lot of intention that went into the type of thing that could be possible with this bill. The bill also explicitly states where the money should go. And I believe that any priorities that this body takes should be drawn from those and not from another plan or any other any other drafted list that might have come from elsewhere. I believe I probably hit around 2 minutes, but I'm really glad to be able to be here and talk more about process. And if there's interest in talking more and learning from the Youth Fund, I'm happy to help connect folks and do that work.
Thank you, Harriet. Up next, we have Debbie Santini, who is an advocate from Maryland. Oh, I apologize. No, up next we have Michelle Smith, who is a Maryland resident, and then following her will be Debbie Santini. So again, that's Michelle Smith, Maryland resident.
So that's Ms. Smith, and we welcome you, Ms. Smith, going once and twice. And we will table Ms. Smith until the next public listening session. Thank you.
Up next would be Debbie Santini, advocate from Maryland.
Ms. Santini also going once, twice. We will table Ms. Santini until the next public listening session.
Now we should have Rachel Peterson from Voices of Hope in the Harford County program. Rachel, you're muted. Sorry.
Thanks. Hey, my name is Rachel Pedersen. I'm a person in long-term recovery for over 25 years and the Harford County Program Supervisor for Voices of Hope. Recovery community organizations and community-based nonprofit organizations like Voices of Hope play a pivotal role in harm reduction and someone finding recovery. I've seen peers connect with participants in a way that clinicians cannot. That's not to say that clinicians don't play an important role, just that a person that has been there before can best understand how someone may be feeling and can share their experience, strength, and hope with them. We had one participant that's been coming in for supplies for a few weeks. Last week, after having built a relationship and some trust with one of our peers, they broke down and asked for help. These are the kinds of things that we're seeing on a regular basis. Another long-term participant called in to share that he was grateful for our help getting him into treatment and that he now has 4 months in recovery and is doing well. We have participants telling us about people that overdose from fentanyl and couldn't be saved. And then we have people coming in telling us that the Narcan we gave them was used to save a life. Our wound care nurse is treating participants' wounds, which keep from adding to an already overcrowded emergency room. The services we offer are at no cost to our participants, and everyone that comes in the door is treated with dignity, respect, and compassion. I'm here to ask that you allocate at least 45% of the available funds to go directly to the recovery community organizations and community-based organizations that are on the front lines so they can continue providing these services and saving lives. Thank you for your work and thanks for your time.
Thank you, Rachel. Up next, we have Don Mathis with Addictions Connections Resource.
Hi, thank you, Chairman Scott, for having this meeting, and I was also delighted to see that Special Secretary Keller has joined the council. My name is Don Mathis. I serve as a board member for Addiction Connection Resources, and I'm also a peer recovery specialist with Voices of Hope. My comments today are my own and don't reflect those of the agency. I submitted my written statement for the record before, and I'd like just to capture 3 basic points and then end on a positive note. Like some of my colleagues, I recommend that funding be prioritized for recovery community organizations and community-based nonprofits. And that's basically because we are on the very front line of meeting people where they are, people who come in from the streets, from very tragic situations that need help, and they trust us. We do a wide variety of services, and it's been mentioned before, these services are free. We don't charge anybody, and we do that. Also, my second point is, one reason our services are important is we support recovery. 6-day detox treatments, they're great. 30 to 60-day treatment programs, they're important and vital, but lifelong recovery is important, and that's exactly what we do at recovery community organizations. We support them, provide meetings, groups, support to other resources so they can continue and maintain the recovery. My third point was, I think the Opioid Restitution Fund money should go to organizations that have the greatest need. I was a board member of a major hospital chain. I worked for a major residential treatment program. I love and respect those programs, but each of them has more than a $60 million trust fund cash reserves. A $50,000 grant to them would be marginal at best. For a recovery community organization, community-based nonprofit, that would be vital. And also what we do is we offset demand for emergency rooms, law enforcement, publicly funded social service agencies, and first responders. I want to conclude. Thank you. Let's go get them.
Don, thank you. Thank you for the opportunity to share.
Up next is David Washington with Washington County Health Department.
That's Mr. Washington going once, David, and twice. And we will table David from Washington County.
Up next, we have Marcy Jones from On Our Own of Maryland.
Hey, everybody. This is Katie Rouse from On Our Own of Maryland stepping in. Good afternoon, council members. Everyone, thank you so much for the opportunity to speak today. I'm Katie Rouse. I'm the executive director of On Our Own of Maryland, and I'm here to voice support for restitution funds being used to expand peer-operated recovery community programs. So for more than 30 years, the On Our Own network of peer-run wellness and recovery centers have provided no-cost, low-barrier resource navigation and peer support services to thousands of Marylanders who are living with mental health or substance use challenges. Peer networks meet people where they are, no matter your diagnosis or your insurance status or what you've had to do to survive. And peer-run centers are a haven and a heartbeat that guides recovery beyond just treatment and into a fulfilling life of health, purpose, and community. Peer-run organizations like ours and in our network and others on this call today prove that recovery is possible and that wellness doesn't come from compliance or coercion or incarceration. What we need are trauma-informed and truly person-centered options. And so we peer-run organizations pioneer healing alternatives to the status quo. One example of this sort of innovation is the peer respite program model. We know that people often turn to using substances when faced with major stress, overwhelmed, or a mental health crisis. And peer respites create a voluntary alternative to emergency rooms or inpatient hospitalization. Imagine being able to stay in a calm and comfortable house for up to 10 days with 24/7 peers who help you learn safe ways to regulate your nervous system, talk through what's really going on, and help you connect with a community of support for the next steps. Peer respites are achieving impressive results around the country, and we're conducting a study right now to bring the case to bring the model here. Funding through sources like the Restitution Fund could make this a reality. But whether it's respite or wraparound or wellness and recovery centers or harm reduction, services delivered by peers for peers reach above and beyond what the treatment system can offer. And we don't have access to many of those funding streams of traditional services. So we strongly encourage the council to prioritize projects and applicants from the peer community. Thank you so much for your leadership, all of you, and for your support.
Thank you, Katie. Next, we have Natasha Brodus from Jordan Peer Recovery, and oops, I apologize. And they are the program manager.
Hi, good afternoon. Thank you so much to everyone attending and for allowing us to participate. I am Natasha Brodus, one of the program managers at Jordan Peer Recovery. Individuals committed to recovery are often challenged by the need for real-time support in the ongoing continuum of recovery. Education, behavior modification, and peer support become valuable tools in the relapse mitigation and recovery process. To support the continuum across the full spectrum, we advocate the use of next-generation behavioral health tools, specifically developed to enable individuals' unique recovery journeys. To support a lasting journey towards ongoing recovery, tools that people use in their everyday life can now become positive enablers activated on demand. Envision a scenario where a person on the recovery journey finds themselves challenged and in need of support. After self-executed bio and psychometric measurements, depending on the level of need, a person can use a smartphone and a consent-based app to receive support designed specifically for their needs, developed from earlier assessments and personalized recovery programs. People can choose from several behavior modification and support channels, from reading journals and self-help articles, educational activities, watching videos, connecting to local recovery programs, and reaching for one-to-one, on-demand, culturally responsive peer support. In extreme cases, a GPS locator can be activated, providing real-time help to those who may need it most from the first responder community. Research demonstrates that people who have access to support networks have lowered relapse incidents than those who do not. In a 2016 study conducted by NIH, the relapse rate at 1 year for individuals once enrolled in support programs decreased from an 85% relapse scenario to 24%. That's huge. The technology currently exists and is available in Maryland. We strongly encourage, thank you so much.
Thank you.
Next up, we have Ms. Christian Geddes from Washington County Health Department, HIV Program Supervisor. Ms. Geddes, going once and twice and tabled until the next session. Cody Harford, Baltimore County Health. Mr. Harford going once, twice, tabled until the next session. Ms. Rachel Peterson from Voices of Hope, Harford County Program Supervisor, Aberdeen.
We've actually heard from Rachel already.
All right, thank you so much. Ms. April Badcock from Lost Voices of Fentanyl founder, Dundalk, Maryland. Ms. April going once, twice, and tabled until the next public listening session. Ms. Tony Torch, Daniel Call Torch Foundation, Baltimore County.
Hi, everybody. Thanks, Tiffany, and for the council for giving us the opportunity for input. My name is Tony Torch, and I'm the director of the Daniel Carl Torch Foundation. So I'm not going to, there's been so many great pieces to this. I'm blowing my mind here. So I'm not going to spend a lot of time talking about how fentanyl was a game changer for us and how the addiction and its tentacles are much different today than they were just even 10 years ago. But I am here to speak on the importance, of course, allocating a large percentage of the Opioid Restitution Fund to community-based organization nonprofits who don't and will not have a fee for services. It's my opinion and in my experience that I think Maryland is doing well in some options and availability for SUD treatment. It's nowhere near perfect. We can agree on that. But we've made some great strides. If you came to us today in painful withdrawal from fentanyl, most likely we're going to be able to find a bed for you before the sun sets. An area where Maryland is extremely weak, and you've heard from a number of people, is the area of recovery support. And that takes on so many forms. It's housing, transportation, clothing, hygiene, food, harm reduction, life skills, and all of that I mentioned, we provide. In February alone, we had provided over 600 forms of recovery. And we're currently funding over 20 people in recovery housing. And the only reason those things are possible is because of a grant. But I can tell you, unfortunately, just this week, we've had to strip our fiscal year 24 grant bare because we have to make sure we have staff to provide badly needed case management and care coordination services. And those are services that maybe some treatment providers should be providing, but they're unable to do so because of their limitations and maybe their staff shortages. So unless someone like me, someone like our organization, that we can find another grant or maybe a daddy warbucks, most of those recovery services are going to disappear. So I will end with this. Anyone on this council that would like to see what a day with clients who are just entering recovery stages look like, contact me. You can shadow with any one of our peer case managers. Thanks for your attention.
Thank you.
And thank you, Daniel Torch Foundation, Ms. Torch. Next up, Ms. Margaret Paul, Office of Consumer Advocates, Washington County. And that's Ms. Paul going once, twice, and tabled until the next meeting. Thank you. Ms. Beth Creek, Youth Empowerment Source, Drug-Free Council, Elkton, Maryland.
Good afternoon, and thank you for having us. My name is Beth Creek, and I am the Executive Director of Youth Empowerment Source, known locally as the YES program. We are a nonprofit youth-serving agency in Cecil County, Maryland. One of the things we're most well known for is our work with the Drug-Free Cecil Youth Coalition. We launched the Drug-Free Cecil Youth Coalition in 2018 with just 2 youth, high school students, and last year that number had grown to over 800 students. Those students take part in activities at their high schools, where every high school in Cecil County now has a prevention club that is student-led. We manage all of their activities in cooperation with our local school system. Everything that we do is grant funded. No one ever pays for our services. I want to just stress to you the value of prevention in our young people. There has never been a time when we need more to invest in the youth that we have coming out of our school systems than now. We're currently collaborating with Community Anti-Drug Coalitions of America to develop a youth coalition model for the state of Maryland. We believe that prevention works, and we're asking for a set aside of at least 30% of opioid restitution funds for prevention initiatives so that we can stop the cycle of substance use disorder. Community organizations and nonprofits need these resources. We, along with our partners in treatment and recovery, are a vital part of the solution and need to be recognized. Thank you.
Thank you, Beth.
Thank you. We do have Mr. Joseph Adams, and he actually has a slide. Is he present, Mr. Adams?
Yes, I'm present.
Doctor.
You don't need my slides. I think I'm not going to go by my slides exactly. They might just slow things down. Thank you very much. I'm here representing the Maryland DC Society of Addiction Medicine, and we support pretty much, I think, everything that's been mentioned already. You know, prevention, peer support, recovery services, harm reduction. All of these are important. I'm just going to talk about one of our recommendations for spending priorities, and that is another aspect of prevention, which is prevention in general, not just in youth. And that is preventing overdose deaths by preventing OUD itself, The overwhelming majority of overdoses occur in people with opioid use disorder. And although fentanyl is now the proximate cause of almost all overdoses from opioids, most people with OUD report that they had initiated their OUD with a prescription opioid. We see this all the time. I mean, it seems like most people that we see have the story that it all started after a motor vehicle accident or surgery when opioid pain medicines were started. And it's well known that this epidemic of overdose deaths and OUD started with the increase in prescription opioids. And even though prescription rates are declining, there's still per capita opioid prescriptions are still higher in the United States than any other country in the world, and still higher than they were in the 1990s. And one aspect of this is relatively straightforward to address, and that is just focusing first on, say, post-operative opioid prescribing for people with acute pain, which of course is absolutely needed. But many people don't realize that one of the most common complications of routine surgery is the new onset of long-term opioid dependence in people who were not using opioids to begin with. Now, there's a number of state collaboratives around the country that have been able to address this very effectively. One of them has been in Michigan. All this is on my slides, which you in the
That's time.
So yeah, we would encourage funding of a similar collaborative in Maryland. Thanks very much.
Thank you, Joe. I'm going to start holding up a piece of paper at the 30-second mark for everyone. I apologize for not doing that sooner, but I will start doing that from here on out.
Yeah. And also with the permission of those who have provided slides, we're able to send them out for those who have registered with their permission. Okay. Thank you, Dr. Adams. We greatly appreciate it. All right, I'll pass it back over to you, Christian.
Up next is Melissa Clark with AHEC West.
Good afternoon, everyone. Thank you, Tiffany and Council, for allowing this opportunity for us to all have some input. Mine is, I've heard so many great things. Mine is more of a process, program implementation, suggestion, thought. I think it's really important that I advocate for the council to consider making the grants a multi-year grant. Oftentimes we are given a one-year grant, and by the time we get up and moving, it takes, then we have to renew the grant. We're writing another grant, and we're taking time away from the services we're providing. At minimum, it should be a 2-year grant, perhaps even 3, much like the HRSA or other federal grants offer. The increasing need to establish trust and help in the communities is going to be better met over multiple years. It helps us cultivate partnerships. It helps us help the public have a shift in understanding. It also makes it better for such services as we provide, such as peer services with the pretrial release detention and the detention center, the ORP, SSP, and a hotline that are investments and endeavors, and these all take time. So I would just advocate that these not be a 1-year only grant. We have 18 years of dollars, and I know it's broken up in different capacities, but I would like for us to see it be at minimum 2, if not 3-year multi-year grants with the proper evaluation tools in place, obviously. Thank you.
And thank you, Ms. Clark.
Up next, we have Tim Lewis from the Torch Foundation.
Mr. Lewis is not present on the call today.
Then we have
I'm sorry to interrupt. It's Chris Venanzo taking his place.
Okay. Do we have Chris Bonanzo on the call?
All right. Is Chris going once and twice? And that is the same foundation. So. All right.
So now we have Beth Harbinson from Sober, and she is the founder.
Hi, I am Beth Harbinson, founder of Bar. It's a play on the words sober and bar. Thanks for this opportunity to speak with the council. And after reviewing the coordination plan, it talks so much about access. And I think that's what I would like to mention to the council today is the importance of access. Oftentimes, a loved one is the person searching for resources, for detox, for rehab, for continuing care. And some of the terms that we use to promote services like behavioral health and other terms like substance use disorder make sense to those of us who work in the field, but the frantic parent, loved one, or person searching in the middle of the night on the internet does not think, let's contact the behavioral health section of our community to find resources. So I would urge the council to really consider taking a step back to look at what we call the resources that we put out there for our community so people searching for them can find them. My son is in recovery from heroin addiction. Joe, I really appreciate you mentioning the importance of overprescribing. He started using heroin after pain pills were given to him post-op in a high school surgery. And 3 of his classmates are dead from overdose from the class of 2005. And my story is not unique. I'm also in long-term recovery and really appreciate the work all of you on this call are doing. Thank you for this opportunity to speak.
Thank you.
Thank you, Beth. Next, we have Susan Doyle from Carroll County Health Department.
And then it's Ms. Doyle once and twice, and we're going to table Ms. Doyle to the next meeting.
Up next, we have Jenny Chance. She is a mother and guardian of 3 grandchildren. If Jenny is unable to join us in a capacity, she did present, or she did submit her written form. Would it be all right for me to read that if she's unable to join us?
Yes.
Okay. All right. I am expected to give testimony today between the hours of 12 and 1. However, I awoke with a sore, scratchy throat, hence the reason for the last-minute email. I'm advocating for my grandchildren and for all children who are left without a parent or parents due to opioids. My daughter, their mother, lost her battle to drugs August 3rd, 2021. The grief is ongoing. The therapy is ongoing for 3 children with no end in sight to date. All 3 children have had to watch their mother fight the battle of addiction, too many rehabs to remember all, and numerous jail incarcerations. While I tried to shield my daughter's children from the atrocities of the beast called opioids, I was no match for heroin or methadone or for fentanyl. It's left its scars on more than just my daughter. Her children have suffered many years, and for the rest of their lives, they will grieve much. It is in my humblest opinion that it should be rendered not only towards the addict, but to children of those who are affected. I have 2 grandchildren who suffer from PTSD due to the behaviors, circumstances, and places they've lived due to my daughter being using heroin, methadone, and fentanyl use. 1 grandson who has developmental delays due to usage of opioid during her pregnancy. My grandchildren will be needing my help for a very long time. I don't have all the resources to meet their needs. Funds should be allocated for all children who have been born addicted or have suffered mental, physical, or sexual abuse due to the use of opioids directly or indirectly by a parent. Thank you for giving me the opportunity to be the voice for my grandchildren, for all children who've been left behind to pick up the pieces shattered by opioids.
And we thank Ms. Chance for offering her written support today. Thank you.
Up next, we have Kimberly Qualls with the State of Maryland.
Ms. Qualls going once and twice. We will table Ms. Qualls. Could we please back up to Ms. Irene Maud from Turk House?
I believe Maud spoke earlier in place of, hi Maud.
Yes.
Earlier in place of someone else from Turk House?
Yes, for Turk House.
All right.
Yes, ma'am.
Yep.
Thank you.
Okay, so now we have Isabel Wewer from Drug Free Cecil at a Youth Empowerment Source.
Hi, my name's Isabel and I'm 15. I'm with the Drug Free Cecil Youth Coalition with Youth Empowerment Source. And Beth Creek spoke earlier. She is one of my advisors. And our group is dedicated to prevention and preventing some of these issues before they even happen. We do a lot of things that kind of promote the idea of prevention and what to do to not have some of these problems in the first place. Treatment and recovery are all good things, and those are super important. But if we focus on prevention, then we won't even need to treat and recover people. So, I'm the next generation, and I have plenty of people who are also the next generation. And if we can get more resources widespread to other schools, if they can have clubs like the ones I'm a part of, and they can have the same network to not even start using in the first place, then the world would be a lot better than it is now. And I think prevention is just really important. And another thing, I think Melissa Clark spoke about it earlier, having extended grants. Drug Free Cecil will be very supportive. It's so much in the longer period of time, but still have so just having one. That's pretty much it. Thank you so much for giving me. Thank you. Please think more about providing funds for prevention that we can help these people before we need to help them in the future. Thank you.
Thank you, Isabel. Up next, we have Stan Seidel, who is a veterans advocate.
Stan Seidel, but I'm glad you can hear me.
Thank you, Stan.
And I've been working on this issue for several years. I'm part of a veterans advocacy group combating substance misuse impacting Maryland veterans, service members, and their families. The one thing that I hear repeatedly is the issue dealing with finding qualified drug, alcohol, as well as mental health counselors. A program that I currently was able to find out was there's a Virginia military medic and corpsman program in which Virginia is now getting people coming out of the military who are corpsman medics and psych techs and putting them and working them in hospitals and treatment centers. I don't see why we shouldn't be looking at the same model or different models of how to find enough people to address the issue. And I can tell you that corpsmen and medics are really very good at doing case management services as we help them get their education to become certified counselors as well as drug and alcohol. Thank you.
Thank you.
Thank you, Stan. Up next, we have William Scarborough, PhD, the Vice President of Health Solutions and Bizzle US.
Good afternoon, honorable council members and guests, and thank you, Tiffany and Kristen. Appreciate all the great work. Bizzle US is a small business administration and HubZone certified strategy consulting and technology firm located in Landover, Maryland. As many of you know, Maryland has a fourth wave drug crisis with stimulant use disorder. After 50 years, more than 100 studies, and 12 rigorous meta-analyses, the best evidenced, most effective approach is called contingency management, which involves motivational incentives. Yet, contingency management is hardly used at all because it's really challenging to manage. But Maryland researchers at Johns Hopkins and Friends Research Institute are world leaders in contingency management and have tested a really unique solution. A breakthrough technology uses smartphones and smart debit cards to deliver contingency management to patients. Funded by 5 NIH grants and the states of Massachusetts, New Jersey, Ohio, and Vermont. This technology doubles abstinence rates versus usual care alone from opiates, stimulants, alcohol, and nicotine. This makes contingency management easy to implement, highly effective, and affordable. Also, it's accountable and auditable with objective, validated outcome measures. Thousands of patients in 45 states have used this tech-based contingency management with very high patient satisfaction ratings. It's now used in states all around Maryland, North Carolina, New Jersey, Pennsylvania, West Virginia, and states have invested millions in these initiatives. And I cite California, Ohio, and Rhode Island as those states that have made significant investments. As a matter of fact, West Virginia and West Virginia Medicaid ran a very successful initiative for its stimulant use disorder crisis. The FDA has designated this program, contingency management, as a medical. Thank you.
Thank you for your opportunity to present today. We appreciate you.
Up next, we have Carolyn McCree with the pretrial OTPS and Yes Care.
Good afternoon, everybody. Thank you so much for the opportunity to present this morning. What I wanted to start out by sharing is this is a really rare opportunity to be meeting with you, and I'm going to talk a little bit about opioid restitution funding and recommendations in the incarcerated setting. So opioid use disorder is a critical public health issue in the criminal justice system. Opioid overdose fatality is the #1 cause of death post-release into the community. It's estimated up to 100 times the risk in the community, the general community. This is thought to be due to a loss of tolerance to opioids when incarcerated patients are not given medications for opioid use disorder during incarceration. Research thankfully has shown that receiving these medications for MOUD while incarcerated does reduce post-release overdose fatality, and it improves treatment retention and reentry in the community. In fact, one jail in Rhode Island saw a 60% reduction in opioid overdose fatality upon offering methadone, buprenorphine, and naltrexone to their incarcerated population. You all might know that in 2019, former administration passed the Opioid Examination and Treatment Act, aka House Bill 116, requiring all Maryland jails to establish programs of treatment for opioid use disorder. Unfortunately, approximately half of jails remain fully out of compliance with this requirement. This due date was January 1st of 2023. Jails report the leading barriers are a lack of funding for medical personnel and for programming. Since House Bill 116 is an unfunded bill and there's a spike of post-release overdose death for somebody who's reentering to the community, I would like to suggest that the restitution funding be allocated in an amount sufficient to support House Bill 116 compliance and longevity in all jails across the state of Maryland, and furthermore to all prisons. This way, patients will not have to undergo a forced taper from their medication once they are sentenced, and will be able to actually reduce post-release overdose fatalities among incarcerated individuals. Thank you very much for your time and attention.
Thank you, Carolyn. Up next, we have Colin Rosier from Pyramid Healthcare, Inc.
Good afternoon, everyone, and thank you for listening to us today. My name is Colin Rosier. I'm a resident of Annapolis and the Vice President of Government Relations for Pyramid Healthcare, which is an integrated behavioral healthcare system that serves over 12,000 substance use, mental health, autism, and eating disorder clients every day across 80 residential and outpatient centers in 8 states. In Maryland, we have 170 licensed residential substance use beds in 3 locations and an outpatient treatment center, as well as the Prince George's County Substance Use Treatment Center that's in development. We urge the council to focus using opioid settlement funds on improving Medicaid substance use reimbursement rates under Medicaid, behavioral health workforce development, the expansion of alternative treatment funds for recovery housing, and support for the transition of the ASO contract to a new vendor. Although Maryland has made some small investments in Medicaid rates over the last couple of years, significant investments are needed to ensure that rates are sustainable in the long term to provide capacity and the appropriate personnel to treat clients with substance use disorder. The council should also recommend substantial funds be dedicated towards workforce development and recruitment efforts and retention efforts, including hiring and retention bonuses for behavioral health workers, student loan debt forgiveness, and the continuation of multi-state licensure reciprocity efforts. In addition, we believe it's essential that peer support specialists and certified recovery specialists be included in that population for workforce development initiatives. Finally, the council should in particular focus funding efforts on developing alternative treatment funds for halfway houses and recovery houses in the substance use space. Neighboring states have done so and found it helpful in expanding the service levels so critically needed by substance abusing clients to facilitate long-term recovery. Thank you for the opportunity to speak with you today.
Thank you.
Thank you, Colin. At this time, as all registered participants have been called upon, we would like to revisit those who did not answer to their names. The first of which would be Carmen Scarpula from Never Use Alone, Inc. All right. The next would be Kimberly Ryan from CCHD.
Table.
The next would be Daniel Morrissey from South Shore Recovery Club.
Table.
The next will be Michelle Smith, Maryland resident.
Table.
The next will be Debbie Santini, advocate.
Table.
The next will be Cody Hafford, Baltimore County Department of Health.
Table.
The next will be April Babcock, Lost Voices of Fentanyl, Inc.
Table.
The next will be Margaret Paul, Office of Consumer Advocates.
Table.
The next will be Kimberly Qualls, State of Maryland.
Table.
And that concludes those who were called not recognized.
So we have about 4 minutes. First, thank you to all who presented today. Your courage doesn't go unnoticed. We all know why we are here. You know, our goal as a council is to ensure that the recommendations and the voice of the community is also heard. There was a poll sent out to you, which we utilize as a framework. It's not in stone of the priorities that were previously set upon prior to the council being implemented. If you have not done so, please join the chat and grab the poll from the chat room and be able to, you also can list comments that are not placed in the poll priorities. It's important for us to hear your voice. Your voice is valuable and inclusion is needed. For all future council meetings, the chat feature will be open and available for you to utilize. You also can submit written statements to the help.org on the OCC's website. I want to thank you for the opportunity for joining us today. All, I can repeat, all presentations are important and valuable, even for those who are not present for us today. We understand there are various meetings going on at the same time on the same day. We hope to have future opportunities for sessions as we move along. We want to see the funds come into the communities and municipalities as soon as possible. And we also need your input. So we appreciate you and your time in this hour spent listening to others, not only presenting your own requests, but spending the time to listen to others. That shows the inclusion and that we are all in this together. And we appreciate you. To our council members who are present, we will take note of what we heard today. And if there's any other comments that could be written, I did not see questions in the chat. and we cannot speak on past council meetings, but I would like to invite you to our upcoming council meetings. Please visit the OOCC's website for upcoming sessions and past minutes, and we look forward to seeing you. Thank you for the opportunity for us today. We appreciate you.
Thank you all for joining us today.
And there is one hand raised, 1 minute shy for the meeting. Did you see that one hand raised?
I believe I saw Jennifer. I don't know whether it went back down though.
Okay. All right. Thank you, everyone. Have a wonderful day. The time is 1:59. Take care.